And the next speaker doesn't need an introduction, but we'll go ahead and do it as well. Everybody obviously knows Dr. Susan Huffnagle, who's a clinical professor of anesthesiology and obstetrics and gynecology at Thomas Jefferson, where she specializes in obstetric anesthesiology. She teaches anesthesia residents, medical students, and student nurse anesthetists daily in the operating room and on the labor and delivery floor. She has been a longstanding member of AOCA, recently completing 6 years of service on the Board of Governors and receiving the Distinguished Service Award in 23. She's the chairperson of the Awards and Honors and the Scholarly Activity Committees and is a member of the Professional Education Committee. She's also an active member of the Society of Obstetric Anesthesiology and Perinatology and the American Society of Anesthesiology. She'll be speaking on OB anesthesiology. Please join me with welcoming Dr. Susan Huffnagle.
In the next 10 to 15 minutes, I'm going to talk about the most recent updates in OB anesthesia, and I have 2 articles that I'm going to go over. I have no disclosures. These are my learning objectives. I'm going to talk about the contribution of suicide to maternal mortality and the anesthetic management of postpartum tubal ligation. Okay, maternal suicide. The article, this is the article and the journal that I got it from, British Journal of Obstetrics and Gynecology. Just so you know where that came from, it was 2024. I'll show you the actual reference in a minute. What is maternal suicide? This is death of a woman by suicide while pregnant or within 1 year postpartum. So this definition carries it out that full first year. And why do we do that now? And they're also classified as direct obstetric death. And the reason to try to do this is to address the underreporting and misclassification of maternal suicide. It is a leading cause of deaths within 1 year postpartum. There are a lot of complex factors involved. We're going to go into them really quickly. And the goal is so that we can pick up on this sooner and maybe train people to try to help these people before it gets to the ultimate situation where the woman kills herself. So there's patient-related, including socio-demographic and clinical characteristics. There's clinician-related, knowledge, experiences, and beliefs, and picking up on some of this stuff. And then system-related. Some of these women don't have access to specialized care that they need, and there's certainly a big stigma around this as well. So this was a study from the Netherlands, Lamercy and colleagues, and they looked at the contribution of suicide to maternal mortality. It's in British Journal of Obstetrics and Gynecology 2024. This was a nationwide population-based cohort study. It looked at from the years in the Netherlands between 2006 and 2020. And what they did was they compared the incidence and proportion of maternal suicide, and then they wanted to identify some risk factors. Some of the characteristics of these women that they looked at were what was the actual cause of death, the maternal age, the marital status, migration background, moving from one place to another, number of children, level of education, and timing of suicide related to the death, timing of the suicide related to the date of the childbirth. So these are some of the results. The maternal suicide rate is 2.6 per 100,000 live births in this study. That resulted in 68 women killing themselves. There was no change between 1996 and 2020 in this study, but the thing that did change was the proportion of maternal suicide to all other maternal deaths. And that increased from 18% to 28%, which is a pretty big jump. And the reason that the proportion changed but not the rate is because there was a decline in other maternal deaths from other causes, meaning that we're taking better care of some of these women that have significant comorbidities. The proportion of maternal deaths up to 42 days from the delivery increased from 5.3 to 8.7%. 81% happened later than 43 days postpartum, so that's why we're saying it should be carried out for that full year. The mean age was 33 years. 75% of these women were older than 30 years. 53% had one child. 33% had migration background, 42% had low level of education, 55%, this is pretty important, had a prior psychiatric history. 65% actually had treatment ongoing at the time of death. And this prior psychiatric history usually was depression. I'm going to show you a slide on that in a minute. Only 2 women in this study had substance use disorder. I think that those results would be a little different if that was done in our country. 15% had social problems after giving birth. And there were no previous suicide attempts documented in any of these women. So what I'm going to show you now is just demographic characteristics, a little hard to see, but I mentioned them before. And then the next graph here is the psychiatric diagnosis. And here you can see depressive disorder was pretty prevalent there as a risk factor. Maternal suicide is higher than any other cause of maternal death in the Netherlands at 28%. Well, how do other places compare to that? It's significantly lower in the UK and France, but in Denmark and Finland as high as 30%. Where is it in the United States? I don't have an actual article, but studies have shown around 20 to 23%. So it's not immeasurable. It's pretty significant. Most suicides occur between 6 weeks and 1 year. And again, people are not necessarily looking out to 1 year and thinking about this, but this study shows that you really have to. None of these were in teenagers. The risk factors most important were a newly diagnosed severe postpartum psychiatric disorder, especially depression, age under 40 years, and I think that at least in our population, we have a significant number of parturients that are older than 40 now. Unmarried status, low socioeconomic status, and a lower education level. So definitely something to think about. In summary, maternal suicides are an important cause of maternal death no matter where you are. That women that have severe postpartum psychiatric disorder are at higher risk, as the study showed. Maternal suicide is significantly underreported, and this is a problem. So hopefully this study brings light to this problem, because we want to try to improve data collection and analysis so that we get the true incidence of this, and then with the true incidence, then be able to train healthcare professionals that are taking care of these women for the risk factors and for some of the subtle things that are going on that might give them an idea that this person needs some help. And again, this has to be carried out through that first year postpartum. And if somebody has some of these signs and symptoms, then certainly longer than that. But I think that there's been a drop-off in people thinking, okay, after a couple of weeks, you're doing fine with your baby, and it really goes all the way out to 1 year, and in fact, more are further along than in the first couple of weeks. All right, we're going to switch gears now to anesthesia management of postpartum tubal ligation. Why are we talking about this at all? Because a lot of us are doing these, and I know when I hear, oh, we have a tubal, I'm like, oh, I'd rather do a C-section. But we're going to go through a little bit of this. This is the article in the journal IJOA, International Journal of Obstetric Anesthesia. We're talking about it because it's one of the most popular methods of contraception in the United States. And in fact, ACOG calls it an urgent procedure with a limited time frame. Limited time frame because after like 2 days postpartum, the uterus goes down in the pelvis far enough that you can't do it by a small incision in the umbilicus. They're also calling it an urgent procedure because if a woman doesn't have this done in her hospital stay having the baby, many insurance companies will not pay for her to come back in 6 weeks and have it done laparoscopically. And then she comes back pregnant again. Anesthesia for postpartum tubal ligation is a couple different ways. Reactivation of an already existing epidural. This has a very high failure rate, 26%. De novo spinal, whereas the success rate is greater than 90%. I'm not tooting my own horn, but that came from a study we did back in 2002. And general anesthesia is the other option, not necessarily as desirable because the physiologic changes of pregnancy, especially airway changes and gastric emptying and things like that, have not totally gone away in the first day or two postpartum. So this study was from Stanford, and Sari was the author, and they looked at the incidence of neuraxial failure rate for postpartum tubal ligation. That's the citation, International Journal of Obstetric Anesthesia in 2024. This was a retrospective cohort study. They looked at neuraxial failure rates for 3 groups: reactivation of the epidural, failure rate of the de novo spinal, and failure rate of a rescue spinal. The primary outcome here was failure of a de novo spinal for a postpartum tubal ligation. They have a very strict criteria in this study for definition of a failed anesthetic block, and definitely we aren't quite as strict with this. But they said if you needed to place a second block, then the first one was considered a failure. If local anesthetic had to be administered in the surgical field, that was also a failure. If you had to convert to general with placement of an airway device, that was a failure. If you required heavy sedation, and this is their recommendations, any use of ketamine, a propofol bolus greater than 10 milligrams, or an infusion of greater than 50 mics per kilogram, and that's not per kilogram per minute, a dose of fentanyl greater than 100 mics, or any use of inhaled nitrous oxide. So what are the results? They had 300 parturients. This went from March 2016 to February 2020. The de novo spinal had 190 patients, which were 63% of the patients in this study. The epidural reactivation was 105 patients, which comprises 35%, and then general, much less, only 5 patients, 2%. And I don't know the reasons why the general, maybe patient refusal, or for whatever reason they couldn't get a regional. So of these 190 patients in the spinal group, 15% had a failed block. That's 29 patients. 28% or 8 patients required a repeat spinal. 38% or 11 patients required deep sedation or local on the surgical field. 35% or 10 patients had to be converted to a general anesthetic. Kind of surprising. Patients with a failed spinal had a higher BMI. That was statistically significant. They did not find any difference between mean bupivacaine dose that was used, intrathecal fentanyl dose if you used some in it, or time between delivery and postpartum tubal ligation. And I kind of get that, but when we go over the reactivation of epidural, there's something that I think is a little bit different, or that I didn't believe. And of course, this translated to longer time in the OR, because once the spinal fails, then you have to figure out what else you're going to do. So this is just a graph showing those results, and this is the statistically significant area. So BMI, again, was statistically significant, and time in the OR was longer when you had the failed de novo spinal. What about the epidural reactivation group? 105 patients. 35% had failed blocks. 35%, which is 37 patients. That's not an insignificant number of patients. 49% or 18 of these patients had a repeat spinal or a combined spinal epidural. 27% required deep sedation or local in the surgical field. 24% or 9 patients had to go to sleep. They didn't find any difference between epidural for labor, time between delivery and postpartum tubal ligation, whether the patient had a CSE or an epidural for labor, or a number of top-up doses. Now, the thing I think is a little bit interesting is this time between delivery and postpartum tubal ligation. Older literature looks at that, and says that the longer the time from delivery to reactivation of an epidural does seem to make a difference in whether that epidural works or not. And kind of the ideal time was anywhere between 4 and 8 hours. And once 8 hours had passed, then it wasn't going to work, and the odds were you shouldn't bother with it. I mean, back when I was a resident, we used to tape the epidural to the patient's back, send them upstairs, bring them down the next day, and reactivate and try for their tubal. I mean, we've since abandoned that because it is a really high failure rate, but we really did believe that time between delivery and the tubal made a difference, and the sooner you did it, the more success rate you had. This study does not show that. And of course, longer times in the OR when you had a failed epidural. And this is just the graphic representation of that. Time in the OR statistically significantly longer. Now, what about, maybe it's just these people at Stanford's technique and it's a poor technique. I mean, doubtful. But they looked at that and they wanted to look at their failure rate for cesarean delivery, which is also done with a spinal. So they had 100 patients that had a spinal or CSE for cesarean delivery. It was the same institution and the same time frame, so matched pretty well with their tubals. They had 4 failed blocks. 2 were spinals, 2 were CSEs. So that was a 4% failure rate versus the 15.2% with tubals, so very highly statistically significant. What is our failure rate for spinal for C-section? I don't know offhand. I mean, I like to think it's not 4%, but it probably is. We're a teaching institution. So why is this happening? That there is such a high failure rate for neuraxial anesthesia for postpartum tubal ligation. Again, these are the results. 35% for reactivating the epidural, 15% for de novo spinal, and then there are other studies that have actually confirmed that. Including us, we've certainly seen a higher reactivation failure rate. And I mean, with the spinals, maybe not so much. But these are some of the theories that are behind this. People are using a reduced dose of local for their tubal. So that might be a reason why they fail. However, in the study that we did in 2002, which again is a long time ago, we were able to demonstrate using 7.5 milligrams of hyperbaric bupivacaine gave us an adequate block for a successful postpartum tubal ligation. And now we did have those patients on their side to put it in, so we didn't lose some of that block height when we had them sitting and laid them down. But so that is, you know, something that might be, probably not. Is there local anesthetic tolerance because these people had local for labor analgesia? Probably not. Anatomic changes in the neuraxis because of that recent neuraxial procedure? Unlikely. Less epidural vein engorgement after delivery. Now, I do think there's something to that, because if you have a pregnant patient and there's a gravid uterus and you're doing a C-section and you lie them down, even with left uterine displacement, you have those epidural veins that are more engorged, and the spinal tends to go higher, faster, and be more reliable. So I think there is something to that. And we do see our tubals take longer for the level to get higher and not near as much hypotension. So we have to wait longer to get an adequate level for our de novo spinal for our tubal than we ever do with our C-section. And we haven't studied it, but it's very clearly, clinically, we see it. I mean, I show this to the residents every day because they're like, why isn't the level high enough? Just wait, it will be. Incision time is higher than C-section, and that is true. It is, and that might have something to do with it as well. And then also some of the physiologic hormonal changes of pregnancy rapidly decrease within 24 hours. Now, not all of them, but some of them do. And I think that one and the anatomic changes with the epidural vein engorgement, I think those are the two most common reasons why it takes longer and you can have a higher failure rate. And I think also the higher failure rate in this study was because they had very, very strict characteristics for their failed and their successful spinals. And the other thing that I think when you reactivate an epidural is, especially the time between when you have the delivery and you start the tubal, is that epidural catheter can become dislodged. And we think that was the reason why many of ours failed back in the day when we kept them in overnight and brought them down and did their tubals the next day. So in summary, Neuraxial anesthesia still is the preferred method for postpartum tubal ligation, but there's definitely a decreased efficacy for spinal for a postpartum tubal ligation. The study showed that. We see that. That you really need to assess the surgical block before you start, because once they've made incision, then you have to figure out what you're going to do. Now, this article recommended using at least the same dose for a postpartum tubal as for a C-section, and I don't recommend that because we use 15 milligrams hyperbaric bupivacaine for our C-sections. Most people don't use that much. We do. We're a teaching institution. It really takes that long, or we'd have spinals wearing off. So I would not use 15. We use between 10 and 12.5 milligrams hyperbaric bupivacaine for our tubals, and I have to say that our tubal times are relatively lengthy too. Again, we have residents in training in the obstetric side of it as well doing these. If you have an epidural for reactivation, or you go back, like say 20 minutes after they deliver and they can do this, expect that you might use some supplementation. I mean, we certainly see that with our epidural C-sections, especially when they pull that uterus out onto the abdomen where it's not supposed to be in the first place. The study recommends adding lipophilic neuraxial opioid. We don't typically, but if you do, don't use a long-acting one, because a lot of these women are going to go home within 24 hours of this. So if you want to add some fentanyl or sufentanil or something like that, that's reasonable. Have a low threshold to convert to general. Well, we don't really want to do that, especially in some of the BMIs of our women with airway changes and things just directly after delivery. So again, that goes back to the point of really assessing whether that surgical block is okay before even starting your postpartum tubal. And be really careful of using very, very deep sedation with an inadequate block, because you know, you're going to end up losing the airway and having to put a tube in or something like that anyway. Thanks for your attention.